Welcome back to the Motivated Mind Zone. Glad to have you here.
It really is great to be back. And today, well, we're tackling something huge. It's more than just language, isn't it?
Oh, definitely. We're diving into what you could call a linguistic mastery set. It's like a professional masterclass pulled together for anyone working in healthcare globally. High-stakes stuff.
Exactly. Think nurses, doctors, medical interpreters, especially if English isn't their first language. They're dealing with incredibly complex situations.
Right. And our listener, you've basically handed us this mountain of material. The goal isn't just learning medical words, is it? It's about that precise, clear communication you absolutely need when lives are on the line.
That's the core of it. We need to boil down, literally thousands of terms, protocols, phrases into the essentials, the toolkit you need for patient safety, for legal compliance, and just making teamwork actually work.
We're aiming to move you past basic English right into, well, professional clinical use.
And let's just ground this whole thing right from the start. There's a statistic that kept coming up in the research we looked at.
Yeah, that 80% figure, it's staggering.
It really is. Over 80% of medical errors aren't because someone lacked the skill or the knowledge. They happen because of miscommunication, pure and simple.
Linguistic failure, basically.
That 80%, that's our focus. If clear language is the key, then mastering the right way to use abbreviations, getting the pronunciation right, knowing how to phrase things in an emergency, that's what saves lives.
So we're trying to close that safety gap, starting right now with the absolute basics of clinical shorthand, the abbreviation.
Okay, abbreviations. First thing to get your head around, and this really stood out to me too, is the usage rule. It's not just a shortcut.
Right, there's a protocol. Is it written only? Is it spoken? Or can you use it for both?
Exactly. And if you mix those up, especially as a non-native speaker, you're instantly creating risk. It's a huge pitfall.
Can you give an example?
Sure. Take
Yeah.
SpO2. Peripheral capillary oxygen saturation, all the sources say. Written only. You chart SpO2, 96%. Okay.
But if you're in a busy ER and you try saying SpO2 96% out loud, well, first, it slows things down. And second, it just sounds wrong. People expect to hear oxygen saturation is 96%.
That makes sense. You lose efficiency and clarity.
Totally. And it marks you out, you know?
Right.
Whereas something like CPR, cardiopulmonary resuscitation,
Yeah, you'd never say the full thing in a code situation, would you?
never. It's always spoken as CPR, start CPR now. The abbreviation is the command in that moment.
So understanding that difference, which ones are spoken commands, which are written notes, which work for both, that's step one for sounding professional and being safe.
Absolutely. It's fundamental.
Okay, let's talk about the big five the sources mentioned, the ones for checking patient stability. These seem to be mostly both spoken and written.
Yeah, these give you that quick snapshot. You've got BP for blood pressure,
Yeah.
the force against the artery walls.
HR for heart rate, beats per minute. RR for respiratory rate, breaths per minute. You need to be able to rattle those off clearly. BP is 120 over 80, HR 75, RR 16. Quick, concise.
And the other two.
SpO2, which we just talked about, write the abbreviation, say oxygen saturation. And T for temperature. You can write T or say T or temperature. Need to check the patient's T.
Got it. Master those five, and you can give a basic status update on anyone.
Right, but then you need to go a bit deeper into the body systems. These are huge for charting, for handovers, for specialists understanding each other.
Yeah, things like CNS, central nervous system.
Exactly. Brain, spinal cord, then CVS for cardiovascular, heart, blood vessels, GI for gastrointestinal, the whole digestive tract.
GU for genital urinary, and MSK for musculoskeletal. Bones, muscles, joints.
You got it. Knowing those helps you scan a chart fast and see who's involved, what the main issues might be.
Okay, shifting slightly patient safety abbreviations during intake, the sources really emphasize two written-only ones.
Ah, yes. NKA and NKDA.
No known allergies and no drug allergies. Why the separate one for drugs? Seems redundant if you have NKA.
It's a critical distinction. Someone might have hay fever, right, an
Yeah.
allergy, but they might not think to mention it in, say, a trauma situation. But an allergy to penicillin, That's life or death.
Ah, I see. So NKDA forces that specific check about medications.
Precisely. It's non-negotiable, often written right on the front of the chart or on a wristband. Missing that can be catastrophic.
And that contrasts with something like SOB, shortness of breath.
Right. SOB is used all the time, written and spoken. Patient reports SOB. Is the patient SOB? Quick, common, understood. But in Kengde, written safety checks. Hashtag, tag, tag B, general intake and assessment phrases, nurse and interpreter perspective.
Okay, so we've got the vitals mailed down with abbreviations. Now, how do we actually talk to the patient? Those initial phrases seem really important for setting the tone.
Hugely important. It's about building that initial rapport, establishing who you are. Starts simple, right? Hello, my name is Name. I'll be your nurse today. Clear, calm, professional.
And then straight into finding out why they're there.
Yeah, you need to know the chief complaint. How are you feeling today? Is okay, maybe a bit general. Often better is, can you tell me the reason for your visit today? Puts the ball in their court.
And then pain assessment. The sources mention the universal standard.
The 1 to 10 scale. You have to deliver this clearly. How would you rate your pain on a scale from 1 to 10? No hesitation. It turns their feeling into a number you can work with. Track progress. Decide on treatment.
I guess that leads naturally into more specific questions about the pain or symptom.
Exactly. You follow up to narrow it down. Does it hurt when you move? Helps figure out if it's muscle, bone, or maybe something internal. And crucially, when did symptoms start? Is this brand new or has it been going on for weeks? Makes a big difference.
And for an interpreter, it's not just translating the words, it's making sure the weight of those questions comes across.
Absolutely. Precision matters.
And the final piece of intake seems to be medication status, another safety layer.
Non-negotiable. 2 key questions. Are you currently taking any medication? And you have to add, including supplements or over-the-counter drugs, because people often forget those.
Oh, point.
And then reinforcing that NKDA check, do you have any allergies to medication? If they say yes to either, then you need details. What drug, what dose, how often. Got to get it all down accurately.
So these phrases, they form a kind of pathway, don't they? From greeting to a safe, comprehensive picture of the patient.
Right. Now let's shift gears. What happens when things go critical? The language shrinks down. It becomes commands, action words.
And the king of urgent commands has to be stat.
Absolutely. Stat, from the Latin statum, means immediately. If you hear, we need a stat ECG or get stat labs down to the ED, there's no ambiguity. It means drop everything, do this now. Patient's in trouble.
Essential for non-native speakers to have that locked in.
Totally. And then you have the core life support terms, the ones you hear shouted during a code blue.
Mostly spoken as abbreviations too, right?
Sure. Universally. CPR, obviously. The equipment. AED, automated external defibrillator. A key finding you need to report instantly. LOC, loss of consciousness.
Okay.
And the basic training everyone needs. BLS, basic life support. These terms are the emergency response. Quick, clear commands.
And in the emergency department or urgent care, the questions are different too, more targeted.
Much more focused. It's about rapid assessment, ABCs. Airway, breathing, circulation. So first question, are you having any difficulty breathing? A yes to that puts them right at the front of the line.
Checks the airway and breathing. What about circulation?
Do you have any chest pain or tightness? You're looking for signs of a heart attack, a myocardial infarction, straight away.
And the sources mentioned a specific question for people who've collapsed.
Yeah, if someone's had a loss of consciousness, you need to know what happened just before. So the question is, can you describe what happened just before you collapsed? Could be a seizure, stroke, syncope. You need those clues fast. Stabilize first, diagnose second. Hashtag, tag, BAB. The crucial role of the medical interpreter.
Okay, let's pivot to the interpreter. Their role is incredibly nuanced, linguistically and ethically. The sources highlighted the first-person protocol.
Yes, this is vital for maintaining dignity and direct communication. The interpreter speaks as the patient using I.
How does that work in practice?
The clinician might start by saying, the interpreter will now interpret everything said in the first person. Then if the patient says, in their language, my chest hurts, the interpreter says, I feel pain in my chest. Not, he says he feels pain in his chest.
Keeps the connection directly between the doctor or nurse and the patient.
Exactly. And it means the clinician has to remember who they're talking to.
Right. They need that reminder phrase.
The simple correction. Please speak directly to the patient, not to me. It gently refocuses the conversation where it belongs. Keeps the interpreter from becoming a barrier.
Makes sense. And this whole relationship gets even more sensitive in areas like mental health, doesn't it?
Yeah.
Because of confidentiality.
Confidentiality is everything there. The rule has to be crystal clear. Everything you share is confidential. But there's that crucial exception, unless there's immediate risk.
Risk of harm to self or others.
Right. The interpreter has to deliver that line with absolute clarity and gravity so the patient understands the legal limits. It builds trust, paradoxically.
And interpreters also guide patients through procedures, using language to manage anxiety.
Yes, translating the physical sensations helps enormously, like before an injection. You may feel some pressure, but it shouldn't be painful. Or for an IV, the nurse is going to insert an IV, it may sting for a moment.
Preparing them for what's coming.
Exactly. It prevents surprises, helps them cooperate, makes the whole thing less scary. It's a key part of the interpreter's skill using language for comfort and control.
All right, let's get into the data. Diagnostics. This is where a lot of that written shorthand really comes into play, defining the patient's status on paper. Hashtag, hashtag, AA, tests, and lab work abbreviations.
Okay, foundational lab tests. You see these ordered all the time, mostly spoken and written abbreviations, like CBC.
Complete blood count, looking at red cells, white cells,
Yeah.
infection, anemia.
Right. Gives you that quick immune and oxygen carrying status. Then there's the CMP.
Comprehensive metabolic panel. That's broader, isn't it? Organ function.
Yeah, gives you glucose, and really importantly, electrolytes and kidney function markers. We also often get a CXR, chest x-ray, quick look for pneumonia, fluid, broken ribs.
And for the heart's electrical activity.
EKG or ECG, electrocardiogram. Universal.
Okay, but then you mentioned electrolytes and kidney function specifically. That's where it shifts more to written symbols.
Exactly. On the lab report, you must recognize the chemical symbols. Ma+ for sodium, K+ for potassium, key electrolytes. Get those wrong, and you risk heart problems, arrhythmias.
Super important to spot those numbers.
Absolutely. And then the kidney markers. BUN, blood urea nitrogen, and CR, creatinine. If those are high, the kidneys aren't filtering properly. Could be acute injury, could be chronic failure. You read the symbols, but when you talk about it, you say sodium level, potassium, BUN, creatinine.
So, written symbol, spoken full name, another one of those key usage rules. Hashtag, tag B, phlebotomy, and sample collection.
Right. Now, actually getting that blood sample, phlebotomy, it's a technical skill, and the language needs to be just as precise.
You mess up the terms, you could mess up the sample, or even hurt the patient.
For sure. You need to know the tools. The tourniquet, that band you tighten to make the veins pop. The collection system itself, usually a vacutainer, the holder, and the vacuum tube.
Someday you need a smaller needle.
Yeah, for tricky veins, maybe on the hand, or in older patients, you might use a butterfly needle. And for a quick finger prick, like for blood sugar, that's a lancet.
And the verbs, the actions you take.
Key actions. First, you palpate the vein, feel for it, check if it's bouncy and suitable. Then you anchor it, hold the skin taut below the site so the vein doesn't wiggle when the needle goes in.
Okay.
After drawing, this is crucial for many tests, you have to gently invert the tube, mix the blood with the additive inside, don't shake it.
Why not?
Because you need to prevent hemolysis. That's the breaking down of red blood cells. If that happens, the sample's ruined, the results are wrong, you have to redraw, waste time, upsets the patient.
Got it. Invert, don't shake.
Okay.
And needle safety relies on knowing the parts of the needle too.
Definitely. The bevel, that's the slanted tip, has to face up for a smooth entry. And the gauge refers to the thickness. Here's a tricky one for non-native speakers. A smaller gauge number means a bigger, thicker needle.
Counterintuitive.
Very. And the ever-present risk, the thing everyone worries about, is needle stick injury. That's why proper technique, using safety devices and immediate disposal are drilled into everyone. Hashtag tech CC radiology and describing findings, 50 terms.
Okay, radiology. Interpreting images. This is where language gets really descriptive, but it has to be clinically precise. And it changes depending on the type of scan, right?
Absolutely. Different tools show different things. An X-ray is great for bones, dense tissues, air. A CT scan gives you amazing cross-sections, good for bone, soft tissue, bleeding.
And MRI.
MRI is the king for soft tissues, ligaments, tendons, the brain, spinal cord, incredible detail. Then you have DEXA scan, specifically for bone density, measuring osteoporosis risk. And pedal scan looks at metabolic activity, how active cells are, often used in cancer detection.
So the words you use to describe what you see depend on the modality. Let's talk pathology first, the words for when something's wrong.
You might start generally with abnormality or lesion. A fracture is obviously a break. A nodule is usually a small lump or mass.
Right.
Then there's fluid where it shouldn't be.
Like edema.
Edema is swelling within the tissues. You see it well on CT or MRI. Effusion is fluid in a body cavity, like pleural effusion around the lungs. And the word no one wants to hear in cancer, metastasis, meaning it's spread.
Okay. Now, how do you describe the appearance on different scans, like on an X-ray versus an MRI?
On an X-ray, it's about density. Something opaque looks white, like bone or pneumonia consolidation, because it blocks the X-rays. The opposite is lucent or radiolucent.
And MRI uses different terms.
Yeah, MRI uses signal intensity. Hyperintense means bright white. Often indicates inflammation, fluid, edema, high water content shows up bright. Hypointense means dark. Could be old scar tissue, fibrosis, sometimes reduced blood flow.
So hyper means bright, hypo means dark on MRI.
Generally, yeah.
Yeah.
And when looking at growths like nodules or masses, the shape is critical.
Oh, so?
A well-defined mass with smooth, clear edges is often, reassuring, maybe benign. But an irregular mass with fuzzy or spiculated, spiky borders that's much more suspicious, usually needs a biopsy fast, suggests malignancy. Getting that descriptive language right is crucial for conveying the risk accurately.
Right. Shifting to treatment. Medication instructions. We're back to those Latin abbreviations, aren't we? And that crucial written versus spoken distinction.
Oh, yes. Prime examples of written only. BID, bisin die, means twice a day. TID, turin die, 3 times a day. You write BID on the prescription, but you tell the patient, take this tablet twice a day.
Saying BID to a patient is just confusing.
Completely. It's a communication failure. The only common one that sort of bridges the gap is PRN pro re nata, meaning as needed. You might write PRN, and you might also say, you can take this PRN for pain, although as needed is usually clearer for the patient.
And the verbal instructions given alongside the prescription need to be super clear, right? No ambiguity.
Absolutely explicit. Things like, take it exactly as directed, a really important one. Do not crush or chew the tablets unless specifically told otherwise, as it can affect how the drug is released.
Especially important for extended release meds.
Exactly. And for antibiotics, the classic. Finish the full course even if you feel better. Vital for preventing resistance. Plus, warnings. Avoid combining this with alcohol or that specific one about grapefruit juice that interacts with so many drugs.
Good reminders. And when actually giving meds, like an IV intravenous infusion, managing expectations is key.
You got it. You need to prepare the patient. Use phrases like, we'll start the infusion slowly, let their body adjust, and warn them about common sensations. You might feel a slight burning sensation at the injection site. That's normal.
Reduces anxiety, makes them feel informed.
Okay, let's broaden out. Healthcare isn't just physical symptoms. We need language for mental health, for rehabilitation. This requires a different kind of linguistic skill.
Starting with mental health, the terms can be quite specific.
Yes, and sensitivity is key. We might use terms like neurodivergent, which is a more positive way to talk about conditions like autism or ADHD, recognizing difference rather
Yeah.
than deficit. And we need to be comfortable using diagnostic terms correctly, like bipolar disorder.
And describing symptoms, I saw terms like rumination.
Rumination, yeah, that's getting stuck in negative thought loops going over and over things. Then there's psychomotor agitation, that physical restlessness, pacing, fidgeting you can see.
And affective flattening. That sounds tricky to describe.
It is. It's a real lack of visible emotional expression. Not necessarily meaning they feel nothing, but their face and voice don't show it. A poker face, essentially. Observing and documenting that accurately is a real skill. It's not sadness. It's reduced expression.
And in therapy itself, there are specific verbs for the process.
Definitely. Good therapy involves actions like the therapist needing to validate the patient's feelings, show they understand and accept them. The patient needs to feel safe enough to disclose sensitive information. And a common technique is helping the patient cognitively reframe, look at a thought or situation in a different, less distressing way.
Okay, shifting to the physical side of recovery. Physiotherapy, rehab. What's the key language there?
It's all about movement, function, recovery. We talk about joint stability or the lack of it, muscle atrophy, that's muscle wasting away from disuse. Therapists perform gait analysis, studying how someone walks to identify problems.
And neuroplasticity. That sounds hopeful.
It is. It's the brain's amazing ability to rewire itself after injury, like a stroke. Explaining neuroplasticity can give patients real motivation to stick with their rehab exercises.
And describing movement restrictions. I saw weight bearing versus non-weight bearing.
Crucial instructions after surgery or injury. Weight bearing means they can put weight on the limb. Non-weight bearing means absolutely no weight, zero pressure. Getting that wrong can ruin a surgical repair.
And symmetrical versus compensatory.
We look for symmetrical movement, both sides of the body moving equally and normally. Compensatory movements are when someone develops a limp or uses other muscles awkwardly to make up for weakness or pain elsewhere. Identifying those is key to fixing the underlying problem. Hashtag, tag, see? Absolutely. When it's time, the instructions are clear, you're fully dilated, it's time to start pushing. Then it's coaching. Take a deep breath. Big push now, combined with constant encouragement. You're doing great. I can see the head.
And preparing for the most intense parts.
You have to normalize the sensation. When the baby's crowning, that phrase is essential. You might feel a powerful burning sensation that's completely normal at this stage. Keep going. You don't shy away from it. You frame it as progress.
And the final moments.
Clear action commands. One more big push. The shoulders are next. And then that moment of relief and connection. The baby is here. You did it, Mom. Shared success.
Then the focus shifts again, doesn't it?
Yeah.
Postnatal care, discharge, dealing with emotions, new physical feelings.
Big shift. Now it's about reassurance and explanation. Emotional normalization. You're doing really well. It's completely normal to feel overwhelmed right now. Validating those huge hormonal shifts.
For explaining things like cramping.
Simple physical explanations. You may feel some cramping. That's just the uterus shrinking back down to size. Demystifying the physical recovery. And finally, clear discharge planning. You'll receive some written information before you go home about feeding, self-care, and follow-up, ensuring continuity, hashtag HAG so on, professional mastery, teamwork, and final takeaways, hashtag tag A, interprofessional communication, and safety frameworks.
Okay, we've covered patient communication extensively, but the toolkit isn't complete without the language professionals use with each other, right? Teamwork, handovers, safety protocols.
Absolutely crucial. This is the language of efficiency and safety within the team. Simple, direct phrases. If you need help, can someone assist me in here, please? No ambiguity.
Initiating handover.
Let's start the handover. Clear signal. When things are going wrong, the patient is getting worse. Then the critical decision point. Do you want to escalate this now, or should we wait another 10 minutes? Clear options, shared responsibility.
And then there are those key legal and safety abbreviations, the really important ones.
Everyone must know DNR, do not resuscitate. A legal order. APAR in the U.S., the Health Insurance Portability and Accountability Act, protects patient privacy, spoken and written.
And SBIR, I see that mentioned a lot for handovers.
Yes, SBR is a lifesaver. Situation, background, assessment, recommendation. A structured way to pass on critical information quickly and ensure nothing gets missed. It's a framework for clear thinking and talking. And finally, QA, quality assurance. That's more of an internal written term for process improvement systems.
That Mr. Chow scenario from the sources really brought this home. The lisinopril dose error.
Perfect example. Nurse prepping discharge meds. Notices the doctor changed the lisinopril dose to 20 milligrams on the chart, but the computer printout still says the old 10 milligram dose.
What did the nurse say? It had to be clear but not accusatory.
Exactly. Professional and direct. I held off processing the discharge medication for Mr. Chow. The chart lists 20 milligrams, but the system printed 10 milligrams. Can you please verify which dose he should be on?
Simple, factual.
And the doctor's response was key too. Thank you. You trusted your instincts and double-checked. The system must have pulled the old order. It validated the nurse's diligence and prevented a potentially serious error. Clear, respectful communication caught the automated system's mistake. ##B. The strategy of clear communication. OE, learner connection. So all of this feeds into a broader strategy for clear professional communication. You see principles like these reflected in things like the OET speaking test criteria. We can boil it down to maybe 4 key steps.
Okay. Step 1.
Build rapport. It's not just being polite. Use the patient's name. Show empathy from the start. That must be very difficult for you. Or, I understand this is worrying. Connect on a human level first.
Step 2. Simplify jargon. This seems counterintuitive for professionals, but it's vital.
Clarity beats complexity every time when talking to patients. You might know the term endodontic therapy, but you say, a procedure to clean the infection inside your tooth. The goal is understanding, not impressing.
Right. Step 3.
Anticipate concerns. Patients aren't just worried about the diagnosis. They worry about cost, pain, time off work, childcare. Be ready to address these real-world, non-clinical issues. Show you understand their whole situation.
Makes sense. And the last step.
Structure and summarize. Every consultation needs a clear beginning, middle, and end. Gather information, explain things logically, and always summarize the key points and instructions at the end. So, just to recap, it massively helps patients remember what they need to do. #C. Final provocative thought.
Okay, let's circle back to where we started. That 80% statistic. 80% of errors from miscommunication.
If mastering this specific, clear, nuanced English, knowing when to say BP, when to say blood pressure, how to explain a procedure simply, how to use SBR, if that's the key to cutting down those errors.
And then the real question for you, the listener, is how much closer are you now to feeling truly confident using this language in those high-pressure moments? Because it's not just about vocabulary, it's about safety.
It's about preventing harm. The language you choose, the clarity you bring, it really can be the difference. #tags5.
Well, that was quite the deep dive. We went from basic abbreviations like SPO2 and NA plus ARI, all the way to safety frameworks like SPR, deciphering MRI terms like hyperintense, and even sharing that emotional peak of, you did it, in childbirth.
It covered a lot of ground. If there's one thing for you, the learner, to really focus on, I'd say it's 2 things. First, master those usage rules, written, spoken, both. Get that right.
And second,
prioritize the reassurance and empathy phrases. Being able to say, I understand, or that sounds tough, builds the trust you need for all the technical stuff to work. It's the foundation.
we really hope this linguistic toolkit helps you feel more clear, confident, and effective in the incredibly important work that you do. Thanks so much for joining us on this deep dive.
Yeah, thanks for tuning in. Until next time, stay curious and definitely stay precise.